Good afternoon and welcome to our first Priority Consult webinar of 2013. As many of you know by now, each month our team tackles a topic that directly impacts our spine center clients. Sometimes we present the idea ourselves, but mostly we like to bring in experts willing to share their knowledge with you directly. At the end of the hour today, we will have hopefully provided you with new perspectives and best practices that you can take back to your teams. Today's topic of nurse navigation obviously clicked with many of you. This is our second most popular topic if you go strictly by registration numbers. Clinical outcomes is the only topic that created this much interest. And that's great because at Priority Consult, we've been advocating for the role of nurse navigator since we began developing our program over 11 years ago. Of course, when we started, we called it care coordination, but the concepts have always stayed the same. At the most basic level, nurse navigators are the glue that keeps the patients, referring physicians, and treating clinicians on the same page throughout the care delivery experience. In so many ways, they become the face of the program for nearly every stakeholder engaged with these multidisciplinary programs. Hospitals with strong navigation programs tend to see higher satisfaction rates, greater ancillary capture, and of course, better coordination of care. Throughout February, we've used our website at priorityconsult.com to address a variety of topics around the development of navigation, including the exploration of what qualities to look for in an effective navigator, a review of navigator-patient ratios, and tomorrow Rachel Elliott will be posting what I think is a very interesting article about how payers are starting to reimburse for navigation services. But today, as our month of highlighting nurse navigation comes to a close, we wanted to back up and simply explain what a nurse navigator does. I'm excited to be joined by three very accomplished individuals, each of whom performs the role of nurse navigator within their respective programs. Today we'll be speaking with Paula Roble of Pinnacle Health Spine Institute in Harrisburg, Pennsylvania, Beth Boudreau from the Spine Center of Excellence at Thibodaux Regional Medical Center in Thibodaux, Louisiana, and Jane Ray, the manager and nurse navigator for the Salem Spine Center in Salem, Oregon. Before we start our program today, I want to take a moment to thank our webinar sponsor, Vega Healthcare. Vega Healthcare offers a free Spine Core Elements review just by mentioning this webinar. You can learn more about how to take advantage of this high-level review and 40-minute discussion of your health system's current status of spine services against national benchmarks at vegahealthcare.com. Our first guest is Paula Roble. Paula has held the role of nurse navigator at Pinnacle Health Spine Institute since the program was created in 2010. In that time, she has helped to provide nurse navigation services to over 5,000 patients. The Spine Institute accepts over 60 new patients each month and has collected clinical outcomes data on over 900 patients. Paula, welcome.
Thank you, Mike. Just a little bit about Pinnacle Health. We're located in central Pennsylvania. We're comprised of 4 different campuses, including 2 acute care hospitals and 1 rehab hospital. Our Spine Institute was created in 2010, and it includes an intake center, outpatient nurse navigation, as well as inpatient care coordination. Our intake center averages about 63 referrals per month. The Pinnacle Health is Joint Commission certified in spine surgery, and we do approximately 1,600 inpatient and outpatient spine surgeries per year between our 2 hospitals. For today's discussion, I'm going to review our intake process as well as the role of the nurse navigator. I'm also going to address how our system transitions the surgical patient from the outpatient nurse navigation to the inpatient care coordination, the role of the care coordinator, as well as what we feel are the exceptional components of our program. The Pinnacle Health Spine Institute consists of providers from their independent private practices as well as other departments within Pinnacle Health. The disciplines within the Spine Institute work together to provide a multidisciplinary approach to treating patients with spine conditions. The intake process begins with a referral to the intake center, and our intake specialist then obtains a thorough medical history from the patient and obtains their pertinent medical records and diagnostic imaging. The completed case is then referred to one of our surgeons for their review and their recommendations for treatment. Treatment can consist of one or any combination of options, such as additional imaging, physical therapy, referral to pain management or physiatry, or even including an appointment with that triage physician. It is at this time that the nurse navigator gets involved in the patient's care. The nurse navigator reviews the physician's recommendations with the patient, providing education on their diagnosis and their treatment. Currently, the Pinnacle Health Spine Institute employs 2 nurse navigators, and we each manage about an active case of about 150 patients at any one time. The main role of the nurse navigator is to do just that, to navigate the patient and their care throughout their course of treatment. We're an advocate for the patient. We act as a liaison for that patient with all their providers. Initially, we provide patient education and coordination of appointments and referrals. Throughout the continuum, we track the patient's progress, the compliance with their treatment, and as well provide ongoing education. At the completion of treatment, we review the patient's outcomes with them, communicate the effectiveness of their treatment with their providers. Once the patient's goals have been met, they're successfully discharged from our program, or they're referred back to their treating physician or primary care physician on an established maintenance program. If the patient has been identified as a surgical candidate and their care is then transferred from outpatient navigation to one of our inpatient care coordinators for ongoing care. So as I said, when a patient is scheduled for surgery, the nurse navigator will review the patient's history and the treatment with the inpatient care coordinator. At Pinnacle, we employ 1 care coordinator at each of our acute care hospitals. The nurse then immediately contacts the patient and establishes a relationship with them. The care coordinator provides all the education to the patient, their families, as well as the hospital staff. The education begins prior to their surgery with the pre-op spine classes and continues throughout their care. The care coordinator is basically not only an educator, but they're also a resource for the patients and for their families. One thing I want to point out about our inpatient care coordination, all surgical candidates get the benefit of the inpatient care coordination. Not all patients go through the intake center. Some come directly from the surgeon's office. But regardless of how they get there, they are entitled and get the benefit of all the education and care coordination. So as I mentioned, the primary role of the care coordinator is education. Our care coordinators provide all the pre-op education classes, which focuses on how the patient can prepare for their surgery, what to expect during their hospital stay, as well as what to expect post-op during their recuperation period. Post-op care focuses on complication prevention. Our care coordinators, they not only monitor the patient's progress while in the hospital, but there's a patient's liaison to all the disciplines providing care for that patient. The care coordination does not end when the patient is discharged from the hospital. Our coordinators contact the patient at 24-hour and 2-week intervals, assessing the patient's status and intervening where necessary and appropriate. The care coordinator remains involved in the patient's care until they're stabilized, or if additional services are needed, the patient's care then is transferred back to the nurse navigator in the outpatient setting. As far as our pre-op spine class, I briefly touched on this, but there's many objectives that we try to reach for the patient. We teach them and prepare them for the surgery. We teach them and prepare them what to expect during their hospital stay. Each campus has a little bit different setup, so we make sure that the information we're giving to the patients is for the particular hospital that their surgery is going to happen at. We review and how to prevent postoperative complications. We review pain management, both inpatient as well as post-discharge. We definitely incorporate the caretaker into the education and how that caretaker is going to be a benefit to the patient once they're home. We go over physical therapy and occupational therapy guidelines. We offer discharge planning, which actually starts preoperatively, and then how to care for the patient once they're home, what to expect post-discharge in those next couple of weeks to months following their surgery. The classes offered to all patients. There are occasions where the patient is, unable to maybe attend a class due to time constraints and such. So we did develop a web-based version of the class or also a DVD. The exceptional components of our program, we feel at each campus we have a dedicated spine unit, and that unit employs dedicated staff for spine patients. We also have dedicated physical and occupational therapy for our spine patients. We really encourage family involvement from the preoperative spine class all the way through the hospital stay. Again, there's that education and coordination. At the onset of the Spine Institute, our surgeons and staff got together and they developed standardized spine orders for both campuses. So all the patients get the same pre-op and post-op orders. And we're constantly looking for ways to improve our process and improve patient outcomes. So in summary, basically, what are the benefits of navigation and coordination? I think the benefits are the same for both. For the patients, it's definitely the education. They are educated on their condition, their treatment options, which allows them to be an educated consumer of healthcare. They have a liaison for them who communicates to all their medical providers. They have an advocate working with them and for them, providing support along the way, giving them education, which leads to decreased post-op complications and decreasing readmission rates, thus increasing the patient's overall surgical experience. So what are the benefits to the navigator or the coordinator? I think it's just knowing that you have made a difference in someone's life. You've provided guidance and support. You've taken an unpleasant experience and made it more desirable with some better outcomes. One of the things I just wanted to share with you, and basically it's just how did we make a difference? There was an elderly gentleman that came through the Spine Institute, and I had him in outpatient for about 6 months. He received all kinds of conservative treatment, which failed in the end, and he ended up being scheduled for some spine surgery. And 2 weeks before his surgery, he found out from his niece that he had to move. He resided with his niece, and she was having a baby and getting a new, smaller apartment, I guess, and he was on his own. So the surgery would not, the surgeon would not do the surgery without this gentleman having a place to go after the hospital. So I enlisted the help not only of myself, the navigator, but the inpatient care coordinator, and we got our hospital social work department involved. And we worked together to find this man an apartment that was handicap accessible. We assisted him in getting transportation for his pre-admission testing, get him to the spine class, and then we began to work on a discharge plan even before he was admitted for his surgery. He was provided with all kinds of community resources so he could arrange additional transportation, Meals on Wheels, in addition to another company providing things for his apartment that he needed. So it's been about 2 months since his surgery. He continues to call every week with an update, letting us know just how appreciative he is for what we did for him at the Spine Institute. And it really would not have been possible without all the disciplines working together, with our main focus being on the patient having a positive experience and a positive outcome.
That's awesome. I'm sure that that's a story that referring physicians and others are going to enjoy hearing as you go out and promote what you can do. A couple of questions for you, Paul, if you don't mind, before we move and speak with Beth a little bit. you're using the terms nurse navigator and care coordinator, not interchangeably, but specifically to define individual roles within your program. Can you just talk a little bit about kind of how that came about, and is there ever any confusion on the part of the patient as to, I worked with Paula for a while and now I've got to work with Margaret, or anything like that, or how do you manage that?
What I explain to the patient from the outpatient perspective when I'm ready to make that transition, I educate the patient as to our roles are basically the same. Our titles are a little bit different. We focus a little bit on different things, but we all have the same goal in the end. And so by explaining to the patient what is the next step in your care, they're all very comfortable once we say, you're going to be talking to another nurse, and here's her name, here's her number, and this is what she's going to do for you. The transition is just very smoothly, and there doesn't seem to be any confusion on the patient's part.
Excellent. Thank you.
Mm-hmm.
Beth, I'd like to bring you in and get your perspective on things for a moment. Beth Boudreau is the nurse navigator for the Spine Center of Excellence at Thibodeau Regional Medical Center. She's held this role since the center opened in 2009. In that time, Beth has personally navigated over 3,000 patients and collected clinical outcomes data on over 800 of those patients. Beth, welcome today.
Okay, good afternoon. I'm going to speak to you today about how to facilitate outpatient care and also how to manage the collection of clinical outcomes data. Okay, we are located here in Thibodeau, Louisiana, and I am the nurse navigator here at Thibodeau Regional Spine Center. I have served as nurse navigator since 2009. I was previously employed at Thibodeau Regional from 1999 to 2004, where I worked on the med-surg floor as a staff nurse. After working for a few years here as the nurse navigator, I realized that every facility will differ in many ways. We may do things very differently from other facilities. We're located in a small community, so as time went on, I learned that I had to fix the navigation and collection of outcomes to fit our population. The Spine Center is part of Thibodeau Regional Medical Center, which has 185 beds, and we have a Level 2 trauma center. We currently have 3 neurosurgeons that are hospital employed. We have 1 PM&R doc and 1 neurologist that are independent practitioners. And we also have a director of the Spine Center. Our average referral per month is 89, and the total referrals for 2012 was 1063. We have a high base of self-referrals down here, and that is due to our small community. We also have referrals which come from Thibodeau as well as several surrounding areas within about a 50-mile radius. The nurse navigation activities. First, I receive the referral either by phone or fax. I call the patient and I collect their signs and symptoms that they are experiencing. I ask them about any previous treatments, diagnostic studies. I get their medical history and their current work status. After the intake is collected, I collect the MRI and any pertinent tests and forward it for review. My job now is to facilitate navigation. I also collect the outcome data on the initial intake to get a baseline. Next, I then educate the patient on our Spine Center process. I tell them what to expect when they come for the appointment, the location of the office, and I answer any questions that they may have. The triage process. After Dr. Cowan reviews the patient, I call the patient and review the treatment recommendations and provide education on his clinical impressions. If the patient is in agreement with this, then I schedule the appointment with the recommended spine specialist. I also call the referring doc, and I also fax the letter to them of the appointment. If the patient is going to surgery, I do the same. I'll call the referring MD, let him know the surgery date, and I also back it up with a letter. The ongoing navigation. I track all patients and their progress. I coordinate the referrals, and I contact the patient regarding these referrals. I do the authorizations for the MRIs, the epidural steroid injections, and therapy. I follow up with the patients to check on their progress for therapy 1 week following their start, just to make sure that things are going smoothly. I check up on the patients the day after the MRI is done, just to make sure that it was fully completed. And also, when they have an epidural steroid injection, I check up on them the day after. For our surgical patients, I call the patient 1 week after surgery, and I remind them of their post-op appointment as well as check on them. I also call the patient after all their post-op visits, and I try to coordinate the call with the outcome form so that it can be completed on one call, because I don't like bombarding them with so many calls. Again, I call the doctor and I send letters to them on all the patient's progress at certain intervals. After discharge from their conservative treatment or discharge from surgery, I began calling patients 4 or 5 weeks after their discharge, because I began noticing that especially after the conservative care treatments, patients were tending to return 3 or 4 weeks later. So before I complete them in the system, I now call and check on them, see how they're doing, and if I feel or they feel they need to come in, then we take care of that appointment. If not, then, they're fine. But the patients love that extra call. In July 2010 is when we started collecting our outcome data. We do our Westry, neck, and the VAS pain scale. Our non-surgical collection is initial 3-month, 6-month, 12-month, and 24-month. Our surgical collection, we do initial, pre-op, post-op, 1 month, post-op 3 months, 6 months, 12 months, and 24 months. Also, at each interval, I check on the patient's work status, as our doctors are extremely interested in how long it took them to recover and return to work. The initial outcome data I collect on the initial intake via the phone, both for surgical and non-surgical patients. We initially began mailing them out, but we didn't have a good turnout. So then we tried to get the individual MD offices to hand them out, but they just didn't have the personnel to handle this. So we came up with trying to call the patient on the initial intake, and that so far that has been great for us. Everyone has been more than willing to give us this information, and they're just so happy that we asked them all this at one time, and it has really worked out well. So as you can see, I had to try and figure out what was best to fit our facility and our population. We do have a lot of elderly patients here, and to send this to them and try to get them to fill it out, there was a lot of misunderstanding. So doing it over the phone has been really, really great. Once I have the initial outcome form completed, then I queue it out for 3-month intervals for non-surgical as a reminder. And if it's a surgical patient, I queue it out for 1 month post-op and so forth. I make between 30 and 50 phone calls per week for the outcome. As each outcome survey is due, we first call the patient. If I'm unable to reach them, then I call them 1 week later, and then I try 2 weeks later. If still at this point I cannot get a response, then I send the outcome survey along with a letter in the mail with a self-addressed envelope. I queue the follow-up out for 5 weeks to allow it time to get back to me. Our collection rates, as you can see, our initial collection rate is at 85%. And then it drops off a little bit, but as you can see, when we do it initially, it's very high. And it is a little challenging as time goes on, but we manage. Okay, the benefits of nurse navigation. First of all, patient compliance. I feel the patients are so grateful when I call to check on them, and it's more personalized for them. I always use the thought that I treat every patient like family. I treat them the way I want my mother, father, brother, sister, or child to be treated. I often tell the patient how wonderful it is to work with them and see their progress, and they just love the tender, loving care. Also, when you guide the patients, they just love the guidance from you, and in turn, it increases our patient satisfaction. And I'll leave you with a little story of a patient that recently called me. It was a referral from a doctor. It was a Thursday afternoon. She was 67 years old. And when I called her, she was in severe pain, and she was crying. And she had told me that she just moved from Texas about a month ago, and she was giving me a little history, and she told me that she previously had a nervous breakdown. And, I was kind of thinking, well, I know she's in pain. I'm just wondering if a lot of this has to do with her previous hospitalization for her nervous breakdown. So I told her, let me get the MRI, which I did. I pulled it up on our computer, and I told her I would call her right back as soon as I looked at the MRI. Well, when I did, I realized why she was in severe pain, because it said she had a right-sided disc protrusion, but more importantly to me is I saw that she had a disc fragment in her posterior back with severe narrowing. And from previous experience of reading MRIs, what jumped out at me was the disc fragment, because I always know when I see a disc fragment, the majority of the patients have went to surgery. So I called the neurosurgeon's office. I told them to please pull up the MRI and show it to the doctor, and within a half hour, that doc called me back, and he told her to report at 9 a.m. the next day, that she could not wait the weekend. So I called the lady, and the husband said, if I have to use a fire truck, I'm going to get her there. Some kind of way we're going to get her there. So they arrived, and she ended up going to surgery that same day. It was in the afternoon. When I talked to her last, she's 2 weeks post-op now. She told me that she is walking, and she's doing really well. She really was a lovely little lady to deal with, and she just loved me to call and check on her, because she's looking for that person to talk to, and she's just doing wonderful. And I love seeing her going through her recovery process and doing so well.
That's great, Beth. Now, Beth, in a small town area like that, being the spine center and being the navigator within that spine center, have you noticed over time that people are starting to recognize exactly what it is that you do, either from the primary care side, or talk a little bit about how that's changed over the years, if you don't mind.
Well, I find as we have become known, we have more people that are calling in. Like I said, we have a lot of self-referrals. And I can't tell you how many people say they have never had someone guide them. Like, if I wouldn't have told them this, they would have never known what to do. I've never had someone, they'll say, I've never had someone that has given me help as to how, like if the MRI was done in another city, I help them look up of where it was to try and obtain so we can get those records. But I've, coming, like I said, from a small community, and the word has gotten out. People talk. We're from a small community. People talk. I've had quite a few patients that call and say, oh, I talked to Aunt so-and-so, and she had wonderful results and said it was wonderful dealing with y'all. So they call. So, that's how things has changed. When we first started out, we just had to get the word out. It took a while, but it's working out well.
Absolutely, and we've seen your numbers. Obviously, the patients are following. Well, thanks, Beth. We're going to get back to Paula and Beth at the end, but I want to bring in Jane Ray as well. Jane is the manager and the nurse navigator within the Salem Spine Center. Salem is a comprehensive program in the Pacific Northwest. Jane actually helped to open the center in 2008. Last year, Salem Spine received 2,200 new patient referrals and collected clinical outcomes on most of those folks. Like our other centers represented today, they have received Blue Cross Blue Shield Center of Distinction. They've also initiated efforts to meet Joint Commission accreditation for their spine program. Jane, that might be a different webinar down the road. I'm looking forward to hearing your perspective on this topic. So if you like, please tell us how it works in Salem.
Okay, well, thank you. Well, I know there may be several callers that already have a spine center established, so I'm just kind of going to review a little bit about what we do here at Salem. So as we all know, there are many different ways a spine center can be developed, and as each of your centers grow, modifications to the initial program design occur, and as you begin to obtain buy-in from participants, including both the independent and employed practitioners. So this slide is a representation of how our spine center works with many different entities, and it's been quite successful. So our spine center is housed in our hospital Center for Outpatient Medicine building, and we consider ourselves a virtual spine center, but only in relation to where we're located and the fact that we work with 5 independent neurosurgeons, and those neurosurgeons are separated into 4 different practices at different locations in Salem. We also have 5 independent physiatrists that we work with that share an office across town, and a total of 5 interventional pain specialists, and only 2 of those are hospital employed. So there's 5 independent neurologists that we work with, and although we have a hospital-based outpatient physical therapy program department, we work with a large number of the independent therapy clinics in Salem. So as you can see, a spine center doesn't necessarily need to offer all services under one roof to be effective. As the program manager and initial nurse navigator, my priority was to create relationships with all the independent providers and their office staff to ensure that we were able to provide a seamless navigation system that actually provided the service to patients and the community providers that we were marketing. One of the biggest downfalls when you say a program is going to offer a service and you end up not being able to offer the service at the level that it was promised is your nurse navigator is going to spend a considerable amount of time trying to repair the relationships and convincing practitioners to commit to sending your center referrals if they feel that the old way was better. So when our program was developed, our neurosurgeons decided that they did not want to accept self-referrals, and they preferred that the PCPs complete the initial workup of the patient when possible and then refer to us when indicated. So this works well for our area due to our location and the communities that we serve. So for those of you at spine centers that have major competitors in the area, I believe that the self-referral is the way to go and a definite way to increase your market share. We may look at that further as we add we're hoping to add a nurse practitioner to our program, and then we'd be able to do that piece. So currently we receive referrals from primary cares, emergency department, urgent cares, chiropractors, and other spine specialists. In addition, all 5 neurosurgeon practices value the spine center triage navigation and outcome tracking that we offer. So so much that they receive a referral, they'll go ahead and fax that referral over to us so that all of their patients will benefit from both our triage program and the inpatient navigation program. So when we receive the referral, we'll enter the patient into the priority consult system and our hospital EMR system. So the referring provider is able to choose which specialist they want to refer the patient to, or if they don't have a preference, we assign the neurosurgeon based on a rotational basis. Per our protocol, if the patient doesn't have an MRI completed within the last year, or if they are an MVA or work injury patient, then the patient is going to be reviewed by one of our participating physiatrists for examination to determine if further workup is indicated. So our intake specialists educate our patients on the value of the spine center and the process that will occur. So this description of the program is our initial selling point of why this process is so valuable to them as a patient. We call our intake coordinators our directors of first impressions. So because how the patient perceives their care from the onset is so important in achieving successful outcomes. So the intake is completed and we determine what imaging or additional testing has occurred or if the patient has had past spine surgeries. So our intake specialists will then obtain the imaging either by having the CD mailed or delivered to us or having outside facilities push onto our PACS system. In addition, they're going to round up all the past surgical or treatment records for the neurosurgeon's review. Now, this is an area where many spine centers differ, but our neurosurgeons like to have all of that information prior to making a decision for the patient. And it's this coordination and having the patient's information in a nice, tidy little package with the imaging ready to go that the neurosurgeons find most appealing and would be a great selling point for any of you that have developed this type of service or are trying to develop this type of service. When the patient reaches the neurosurgeon's queue for review, they are very thoughtful with their initial impression and recommendations. As we all know, there's a multitude of spine treatment options, and our neurosurgeons are making every effort to be cost-effective and to utilize evidence-based medicine in their treatment decisions. When our patients are in pain, they're pushing to have every treatment done, and many times they voice the need that they need surgery, whether it's indicated or not. And I'm sure many of you have experienced that. But it's at this point that in our process that our nurse navigators are key in educating and convincing the patient that surgery is not always the answer. Generally, about 80% of the time, the patients don't need surgery. So the Salem Spine Center practitioners are dedicated to utilizing the best practice choices in their decision-making, and we've incorporated a very conservative approach to the treatment options that we recommend. And with the utilization of the nurse navigators tracking their patients, the neurosurgeons and physiatrists are confident that the patients will not get lost in the system. Since many of our practitioners are independent providers, they tend to be in their own private world. With the changing times, they're not always aware of what the most effective practices are or what makes them that way. So through the use of the nurse navigators, the spine specialists have been able to develop a collaborative approach with open exchange among equals to review treatment options and to develop algorithms, standardized care practices with knowledge that the nurse navigators are tracking the results through the use of outcome monitoring, follow-up calls, and making sure nothing gets dropped and all of the pieces are flowing together. Next. In stage 2, the patient enters into the nurse navigator's queue. So like the other ones, our navigator will review the recommendations and then contact the patient to discuss the spine specialist recommendation. During that time, the nurse educates the patient on their underlying condition as well as the treatment options that are recommended. If the spine specialist recommends additional imaging that they need either before an appointment or before they can make a decision for the patient, whenever possible, we will obtain the insurance authorization for the patient and arrange the imaging appointment. So this helps to expedite the imaging process, and the patient generally knows within a matter of minutes that we have auth in place and they're scheduled with a date, time, and the facility of their choice. We will also assist with a referral to physiatry, interventional pain, and physical therapy as indicated. The neurosurgeons are able to select which provider they wish to refer to, as many of them have established, not partnerships per se, but relationships with those providers. And so, but if not selected, we will assign them on a rotation system or per patient preference if they've gone to a provider before. If the patient insurance dictates that the primary care doctor needs to be the one to obtain the authorization and refer the patient for any recommendations, then our nurse navigator will contact that office to help facilitate the process. So our ongoing navigation process is facilitated through the use of the Priority Consult software. And we have an ongoing queue, and the patients can be sorted either by dates that we select for follow-up or reason or type of follow-up. So I believe the ongoing tracking is one of the most individualized areas per center. So how much follow-up the center can do certainly is dictated by the number of referrals and patients you are tracking as it relates to the number of nurse navigators you have in your program. So we decided not to track patients that have appointment with a neurosurgeon as a impression and disposition. Basically, on those patients, we facilitate moving the patient to the scheduling queue for the individual office. And at that time, the neurosurgeon office manages their own patient. However, they do enter the appointment into Priority Consult so that, that we get the notification and we can notify the referring practitioner from our end. In the event that surgery is scheduled for the patient, then our navigator picks up those patients off the surgery schedule and enters them, the surgery into the system, and then they're entered into our surgical patient program. So what we actively manage is the patient testing, interventional pain, physiatry patients, and one of the areas that we are attempting to follow closely as to practice patterns, effectiveness of treatments, and outcomes is our interventional pain specialist. So I'm generally tracking, on average, over 100 active interventional pain patients at one time. So while we're monitoring the patients, we will be updating the referring practitioner via fax reports and letters at the appropriate intervals.
Now, Jane, something that isn't on this slide, but I know you do, and it's similar in a little ways to Pinnacle, you have a pretty heavy inpatient presence, at least individually, including rounding patients. Is that correct?
Yeah, that is correct. I'm involved in all of the interdisciplinary care rounding on the patients on the inpatient side. So each morning we round, we have a meeting at the interdisciplinary board where we review patients. I'm able to help tell any discharge barriers that may be happening, that sort of thing. And in addition, I round with my inpatient navigator and the nurse manager of our neurotrauma care unit where our patients are housed. And with that, I'm able to meet the patients that I've triaged or we've triaged through our program and have seen us through the whole process, just to kind of get a feedback from the patient on how the program was, if there's any things that we can change for our program. And, you know, we get to hear the patient stories, and they just feel a lot of plus the fact that at that time when I'm seeing them in the hospital, I'm also going to be telling them that they're going to see my name for the next 2 years because I'm going to be sending them outcomes. And with that, then they're, oh, yeah, the outcomes, yeah, absolutely. I knew I recognized your name for somewhere. So that's been really helpful to do that piece, and it's just a nice closing touch with the patient.
But you weren't doing that from the very beginning, right? You had to get some support. You know,
well, actually, yeah. Well, in the very beginning, before our referrals grew, I actually did go in round on the patients that I had navigated through the system. But then, as our referrals got more, then I couldn't do it because I had to focus on the patients just coming through the program. I just didn't have the time. So when we were able to hire the inpatient navigator and then an initial navigator to help here in the triage center, then I was able to incorporate that back into my routine. And in addition, on Fridays, our medical director of the program, he actually rounds with us on all the patients that have had come through our Center of Excellence program and classes and that sort of thing. The only ones he doesn't round on with us, obviously, are his patients because he doesn't want to make them be biased towards him. So he rounds with us, and and actually it's funny kind of some of the stories that we get from him or that the patients tell our medical director. So he has a really good sense if a patient's kind of reluctant to share something. He's quite personable, and he's able to kind of bring things out. And I think the patients really enjoy seeing another physician that's taking such a vested interest in a program to make it happen. So that's what we do on Fridays.
Great.
Yeah.
And it helps with outcomes, you say, to have that relationship.
It does help with outcomes, yeah. And then also it helps kind of get my patient stories, you know, for future stories. Like yesterday, we ran on a patient that had surgery back in 2010, and they didn't go through our program, but and then just recently he did. And even though he had the same surgeon the previous time, he was thrilled with the changes that had occurred with our program, starting with the initial screening of our triage program to the pre-op class and the follow-up on the floor. He said that it's just been such a great change, and it's just an excellent program. And, you know, patients really sell your program. And he even said to us then, he said, you know, if he knows anyone that needs back surgery, he knows exactly where to send them. So, I mean, it's all word of mouth that makes your programs grow. So that's so once we've discussed with the patient the spine specialist recommendation, then our navigator lets them know that our spine specialists are very interested in tracking the improvements they've made, and we'll be sending them several outcome surveys via the mail at selected intervals that we'd like them to complete and send back. So along with the outcome surveys, we also refer them to our website where they can watch videos that relate to their condition, and we send a colored printout of that initial impression as well to help reinforce the education our navigator provided over the phone, since sometimes our patients don't necessarily have access to the internet. So currently the outcomes that we gather as part of our program are pain utilizing a numeric pain scale, the modified Oswestry Disability Index, and the NEC Disability Index, return to work status, patient's perceived % of improvement, and the patient satisfaction. So we're similar to Beth. We conduct the surveys at the same intervals that she mentioned before. And then, but however, if the patient does, we mail out all the outcomes. And then if the patient doesn't return the outcome by mail, we'll contact the patient to complete the outcome over the phone, because that can be a very time-intensive process for us. So we are also looking into implementing the internet option that Priority Consult offers this year, just to kind of explore another avenue for the patients, because everybody's, kind of connected to their iPhones and iPads, so that maybe we may be getting an even better increase with that. So, and we do utilize our outcome data as part of our Blue Distinction accreditation, scoring for our COE metrics, and benchmarking. In addition, we're using the outcome reports to assist us with a peer review process for practitioners with all of the participating providers. So, and let's see, recently also, it was interesting that you mentioned that Rachel's going to have a blog out there on Priority Consult about insurance providers, because I did meet with one of our large insurance providers, and they've indicated that they are going to start requiring functional outcomes in the form of oswestry to be collected at pre-op as part of the authorization process, and then to be reported again to them at the post-op 6-month interval. So I was glad we already have this process in place, and the navigators really helped to increase the percentage of returns on those surveys. And I imagine we'll start to see this as a standard with insurance companies as we see more comparative effectiveness data being utilized. So the intent for this company is that our outcomes are going to be benchmarked against all participating providers to establish more of a gold star system for services and providers. So that's something for you all to keep in mind. So this is just a view of one of the many reports you can have when utilizing Priority Consult's outcome feature. So this report is based off of my oswestry and neck disability functional outcome surveys. Our inpatient nurse navigator utilizes this report to trend over time to see how our patients are doing, as well as the 6-month report. Like this report serves as our metric for the reporting to the Joint Commission for data collection, and then it's also our peer review trigger for anybody that declines at that 6-month interval. Then we will contact that patient, either get them back in the process, or we look at all of the different treatments that the patients had to report out to the different practitioners if they've fallen off of our algorithm. So this report's kind of a sample report that shows our response rates for the surgical outcomes at the post-op 1-month interval. We didn't begin gathering post-op 1-month outcomes till January of last year, and then the inpatient nurse navigator was hired in February. So as you can tell from this report, we've seen a definite improvement in collection rates. It's always easier to get patients to respond during the earlier phases of treatment, but we have seen a trend upwards in all of the collection intervals with our nurse navigators' efforts. So just another example of the many ways that a nurse navigator can enhance your program. Now, Priority Consult recently conducted an internal survey of the spine centers utilizing their service to find out the common nurse navigator to patient ratios. So there were about 23 programs surveyed with that, and our program triage, 2,200 plus patients in 2012, and I have basically 1.5 FTE nurse navigators for my triage program, because I kind of serve as that 0.5 FTE. Now, when I have a lot of management things going on, then my nurse navigator feels like it's only a 1.0. So anyway, but this seems to be the most common ratio, and I imagine that those centers having the much higher ratios that you would see at this graph in that 3,000, 3,500 may be simply triaging and not spending as much time with the ongoing tracking and outcomes of their patients. So it just depends on how robust of a program you want to develop as to how many navigators you'll try to justify for. So another thing to keep in mind is that the use of clerical staff to help support your program, because this will help you manage the higher number of patients at less cost, not having to add on additional nurses. And then everybody, once in a while I get calls on, our return on investment and just basically how to justify for spine triage navigation and the spine center itself. So one of the major return on investments that I concentrate on is increasing referrals to our program. And as you can see, our referrals have been on a steady incline each year. Another type of return on investment that we monitor for is justification, is the downstream revenue that the navigators create, including the imaging, physical therapy, chronic and interventional pain program referrals that are hospital-based. We utilize Epic at our hospital, and I enter all the patients into Epic in order to create the MRN number if they're not already there. And then I'm able to pull that patient information from the Priority Consult triage system, and I send that to finance to generate my downstream revenue report. So, like, for example, my net income for downstream revenue from 2011 was over $2 million. So it doesn't take long to obtain buy-in from your administration when you're justifying what effect your navigators have on the bottom dollar. So, in addition, freeing up the neurosurgeon offices of the non-surgical patient, like I said, 80% don't need surgery, so that's really lended itself to them seeing more surgical patients, not having to spend time with the other ones, and so the increase in surgical volumes over the first 4 years of our program has also been a definite return on investment. So we've developed several algorithms to utilize within our spine center. Now this one is actually the acute cervical and lumbar back pain algorithm, and it's one that we've been using in our educational and partnering program that we provide the primary care doctors in the community. So this one just provides a general overview of the basic steps that you can take in directing their patients to the most appropriate care, as well as showing them the optimum time to refer the patient to our spine center. So, and on the right-hand side, you'll see the overview of the red flags that they should be looking for, so that then they would know that that's something that needs to be escalated, as well as we always look for those red flags when we're doing the intake process. So Dr. Collada, our medical director, and I meet with the providers at the offices to review this information in person. Usually we provide them lunch, along with presenting case studies to show how we're using this and the other algorithms that we have specific to our spine center, and we've developed to direct our patient care decisions. So it's been very well received by the practitioners, and they appreciate the fact that we're coming to their offices, and actually they can get those specific questions that they need answered on what to do with their patients answered by a neurosurgeon, because a lot of times it's the same questions that they have and they're not quite sure how to manage that. So that, you know, the more personal touch from the spine center has really had total buy-in from the community practitioners. So.
Hey, Jane,
Now,
I want to make sure that we, real quick, that we have enough time to answer a couple questions, but I really want to talk about the Affinity Group. Do you mind if we flip to that just for a second?
You bet. You bet. Yeah, because we do have like 3 groups. You can say we do have 3 councils that we utilize that do all kinds of great things. So, but one thing specifically that my inpatient navigator is involved in is our lumbar fusion, or it's basically our spine center affinity group. So our initial work's been on reducing our length of stays for our lumbar fusion patients. And for those of you who are not familiar with affinity groups, they're basically physician-led groups focused on standardizing care in order to reach a financial goal. So our navigators, the operational lead, like I said, and she's this group identified that one of the main opportunities was to increase revenue was with coding and length of stay for our lumbar fusion. So this slide demonstrates our assessment of the current situation, basically what was happening, what should be happening in the gap. And so the projection is that with this group that we would experience a potential of $350,000 in savings if our length of stay target is achieved this year. So, and we've really made great gains with that. I'll show you that on the next slide. But so, and then after they work on the lumbar fusions, then they'll be starting to analyze OR time and looking at eliminating waste and using the precious OR time effectively. So as you can see, this graph shows our initial length of stay, which is pretty high, and it's been trending down since the inpatient nurse navigator was hired. So the green line is our peer mixed group, and the goal is for the blue line and the green line to meet at our target. And it's generally accuracy in coding and charge capture that'll bring that green line closer. But as you can see, we've been making gains as well since the Affinity project was started. And actually in January, our length of stay is now down to 2.64 on our single lumbar fusion. So they've really done great work there. So as we've improved the efficiency and collaboration by utilizing the nurse navigators, this helped to align our surgeons and obtain buy-in for all of the cost-saving initiatives that this group is proposing. And they're focused on all of the Affinity Group initiatives, peer review and responsive to coding, and the documentation standards that's required. So, and then, okay.
That's great, Jane. And you know, we've got a few more minutes left, and I'm going to let Jane take a glass of water, drink of water, because I've made it.
Sorry.
No, that's great. We had a question pop up while you were talking about. And this is a question from Gina, and she wanted to know if you're an employee of the hospital or the group, and I could go ahead and answer that. All 3 of our navigators here are employees of the hospital-based spine program. But talking about pre-authorization, and the question basically gets to how can you do pre-authorizations if you're not calling from the actual referring physician's office. And this may be a by-payer scenario. But can you talk a little bit about how you make that work?
What happens is they send me the office notes of the office visits, you know, whether it's the first, second, whatever. They send me all the information I need. And that's basically how I do it. I have the physician's typed office notes in front of me before I even attempt to pre-cert. Does that answer? Because it has, you know, I know what conservative measures they've done basically by the intake, and also if they saw Dr. Cowan, let's say they saw Dr. Cowan, he recommends 4 weeks of therapy with him from the office notes. I know when they initially called me, and then he'll put that they went to therapy and what medications he put them on at that time. And so I have all the information right there in the notes that they faxed to me to pre-cert.
Do you find that on occasions you have to go to the referring physicians for those all-important signatures, you know, whether it's therapy or maybe in some cases imaging requires a little extra? And that might be a question for all three of you. Do you find that there's a need to understand who the payer is and then change your patterns accordingly?
Absolutely. I mean, go ahead, Beth.
Go ahead. Go ahead.
Yeah, I mean, many of the insurances have very specific requirements that the primary care be the one that's the ordering practitioner. So at Salem, we send a letter with the impression and also contact the office to tell them what the neurosurgeon is recommending, and they need to help us with that authorization piece.
Paul, how do you keep it straight with two navigators sharing patients? Do you, or what's your process for that? Especially around things like authorization.
With Priority Consult, it pre-assigns one of our navigators to the case upon initial intake. That's kind of how we have it set up. So I have my own patients that I'm working with, and then my counterpart has her own patients, and we're responsible for everything for those particular patients. And then we cover for each other if someone's on vacation.
Gotcha. The couple of minutes left, we had asked registrants to submit questions in advance, and there were a lot of folks who were talking about wanting to start a program up. So maybe before we end the meeting today, and I think we'll be right about on time, we'll go in the same order of Paula, Beth, and Jane. But to help us with maybe one or two ideas for those who are just getting started, whether it's about, you know, selling the concepts of navigation to administration or just designing a program that's sustainable in the first couple of weeks, in particular a couple of months. It struck me when Jane mentioned that, you know, the worst thing you can do is overpromise on something like this. So maybe a couple words of advice for those who are just getting started. Paula?
I would say, just from my experience, I think it's having the right people in the right positions. I think we're very fortunate here at Pinnacle that we, with our nurse navigators as well as our care coordinators, they all had backgrounds in orthopedics and spine, as well as in the outpatient sector. We were case managers prior to assuming this role, and I think that the role of a case manager and the duties of a case manager are very similar to those of nurse navigation. So I would say that's probably one of the keys when you're looking at starting a program. You want to have the right people in the right positions.
That's great.
And I would concur with what Jane said is when you're out there selling your product, not to overemphasize or set the expectations so high that you cannot meet that. I think you have to sell your product based on fact, based on best practices, and what you can provide, and build on that then.
Because you can always go back and promise more later.
Exactly. Make yourself look good the first round.
We tell every new program the same thing, and sometimes the folks even listen to us. That's great. Thank you. Beth, did you want to add anything from your perspective?
Well, I'm going to say like her, you have to have the right people. But another thing was, you know, we marketed a lot. And then we, just like I said, you have to figure out what fits your community. And, you know, we all from different places. We all have different types of people with cultures. So, you know, we kind of had to figure out as time went on what fit our hospital, our people here. And that's kind of how, you know, it took a while, but that's kind of how we started off. And, you know, then it eventually took off.
That's great. Jane, you want to have the last word?
Yeah, well, with mine, you know, I had to implement the program from ground zero, and I had only ever worked in the inpatient in the hospital for 25 years. So actually for me it was hiring somebody that was very familiar with the outpatient setting, you know, doctor's offices setting. So the fact that I hired somebody that had knowledge about the insurances and the insurance authorization piece, coding, referrals, how all of that worked, because she was invaluable to me as far as things that I didn't even think about when I was starting the program that I needed to make sure. And basically just the feelings of what the referrals and how these doctors might you know, take this type of program. And the second thing real quick would be that I definitely want to start out with a test group, you know, start out with one neurosurgeon office that you're going to do this with. Make sure you get all the kinks out with a small population and then move on. So don't do the Big Bang Theory, I'd say.
Very good. You know, we have the pleasure of working with, I think we're up to like 45 or 46 spine centers, and the Nurse Navigator is a common element of every one of those programs. And every time I get a chance to visit the program, this really is the role that I always count on to make a program successful. You guys are the face of the spine center for so many different people. The patients, of course, which we've talked about quite a bit today. We could have spent an hour probably talking about how you interact with the docs and make them feel comfortable with sharing their patients with the program, referring physicians and, gosh, employers and everyone else out there. Your role is so critical to what happens in these programs, and I really appreciate the chance for you guys to talk about your 3 programs today. You've all done wonderful jobs, and I hope that our attendees for the webinar today have learned something. We're going to do this every month. Next month, we're going to shift away from nurse navigation and focus on clinical outcomes. That's another very popular topic that deserves quite a bit of attention. So I invite everyone to stay tuned to our website for blog posts and case studies, and obviously the next webinar, which was always going to be the final Wednesday of each month. And look forward to seeing you all again. So thanks again, guys. Paula, Beth, and Jane, you guys did this on your own time, and I know that I learned a lot just from listening to you, and I assume everyone else did as well. So thank you, everyone, and hopefully we'll see you again next week or next month. Bye-bye.